So if that's good, we'll go. I'll do a bunch of case-based kind of stuff on respiratory, and then we'll carry on, and if we have time, we'll do some other stuff as well. But you don't mind if I sit? I don't really have a penchant to stand. I'm just coming off night, so I'm kind of not feeling like standing and chatting. So anyways, we'll get going. If you have questions, just stop me, but we'll go through. I think there's, I want to say, at least 7 cases that I put together of different varying topics on respiratory emergencies. So we'll go through it, and then and we'll have a check. So topic, we'll talk primarily about pediatric respiratory disease, because I think primarily for you guys it's seizures or respiratory issues with kids primarily, I think, is probably the 2 main components that you guys get called to see kids for. I have another presentation that if we don't have time for it tonight, we can do, but just talking a little bit about seizures as well, but we'll carry on. So it's a big part of, our business in emergency medicine. So 10% of all pediatric emergency department visits are kids with respiratory distress, right? And it's obviously higher at certain times of the year than others for us, particularly fall and spring. Spring primarily with asthma, fall primarily with bronchiolitis and croup and that kind of stuff. So 20% of visits in kids under 2 years old, and then 20%, so 1 in 5 of the kids that actually get admitted to hospital are kids with respiratory distress, and 30%, so a good chunk of their business, like 1 in 3 kids that gets admitted to ICU, is secondary to respiratory distress as well. So it accounts for about 5% of deaths in children and 20% in infants. So it's a big part of what we do, right? And something that you guys commonly see and manage, particularly, if the kid's in severe respiratory distress. So it's just so we'll just talk a little bit about the historically and physical exam features in the pediatric population. We'll talk about respiratory distress, respiratory failure, and then we'll talk about the anatomy of the upper airway, lower airway, and specific lung respiratory emergencies. And like I said, once we get through that, then the majority of it's case-based, so we'll roll through some cases. So what are the critical historical features that we look at, right? So onset and duration is similar to anything you guys deal with. We want to know what time, when did this start, how long has it been going on for, is there any exacerbating factors, right? Like, has the kid been sick with a viral illness? Is it, were they just chewing on a toy and swallowed it? Want to know that. And want to know associated signs and symptoms. Want to know in young kids, want to know the feeding pattern. Are they choking with every feed? Those kinds of things. I have choking episodes, but it's actually supposed to be choking episodes. I misspelled that. So is there episodes of choking? Is there baseline noises? What's the quality of their cry and their voice? All those things are kind of important to kind of put the picture together. So past medical history is important, obviously. Family history, history of asthma, those kinds of things. Immunizations up to date, certainly that's important, particularly with infectious causes of things, and particularly when we think of epiglottitis, right? Because how many of you guys have ever seen epiglottitis or thought you had a case of epiglottitis in your... It's not very common anymore, right? And the reason for that is because of immunizations, right? The most common agent that causes epiglottitis is Haemophilus influenza, and kids get immunized for that now, right? So, there's a reason why, we see less of those things, and it's because of the success of immunizations. Want to know medications. Is the kid asthmatic? Is he on, inhalers already? And then physical exam features, right? So vital signs are important, obviously. Rate of respirations, the mechanics of the kid's breathing, and then mental status. and you know, is the kid alert and awake? Because obviously if the kid's alert and awake, and you know, not working very hard to breathe, I mean, most of you can tell that just by eyeballing a kid if the kid's really in trouble, right? So and then cyanosis and skin color, obviously, if they're really, you know, if they're blue and you know, look pre-arrest, then they probably are, right? So I won't play the video. I've got a couple videos. I'll see if I can get them to pull up. I don't know if I can never seem to make this work, but I'll try and just see if we can. I'll try and attach it to, if I'm hooked up to your internet, I'll try and attach it to a browser here and see. This is the first time my computer hasn't gone all whacked when. Well, it looks like I'm hooked up to the internet, so I should be able to pull that in there and we can look at a video or two here and, oops. Come on. Never wants to do this properly when I'm, let's see if it works. We'll probably have to wait for a few ads to play and then.
Back pain used to be a problem. Then he discovered Voltaren Emulgel with its...
Let's go full screen here. So I think you guys can all appreciate in that kid, like just the indrawing there and the subcostal retractions, right? Like that kid is obviously having difficulty breathing, right? That's why it's important to fully expose these kids and have a look too, right? Because you wouldn't necessarily appreciate that if the kid was clothed, right? We'll look at a kid with stridor here. There's probably a few that come up here, so I'll just watch a few of them. And so that's stridor, right? That's the typical sound you hear with stridor, right? So that's a pretty glaring example there. And even that kid, again, you know, seeing the just the way the kid presents is helpful, right? Those are projecting okay? Yeah. Oh, this is, we'll close that off there now. I had one more. I think we'll see if we can escape it out, and we'll see if I can go back to.
With an abnormal.
I'll try and pull this one over too now. See if this one works. So again, you can see that kid's working hard to breathe. They got the head bobbing going on and everything else, right? So again, you know, that kid's at rest, right? And that's the way the kid looks, so pretty impressive. And then there's a kid with stridor and retractions, right? So you can see even just like this, the whole sternum is retracting in that kid, eh? It's pretty pronounced and impressive. So I think that's it. We'll see what this one is. I can't remember if this is. Looks like it's working. I'm sure it'll come up. Anyways, that just gives you the idea of the kind of stuff, like on physical exam, that you're looking for. So, you know, it gives us a bit of a framework to think about and how, you know, kids present, right? And often you guys are seeing kids after, you know, the parents freak because, you know, they see their kid working that hard to breathe, right? And then all of a sudden you guys are called and you're the first to see. So it's certainly significant. What is that? Yeah, so modeling. You can see that in some Caucasian kids as a normal phenomena, right? I'm sure I looked like that when I was a little kid all the time, but it's typically that's abnormal, right? That's mottling. So when we talked about respiratory distress, respiratory distress is reversible, it's compensated, and you get dysfunction of the ventilatory respiratory pathway. When we're talking about failure, you're talking about inability to meet the metabolic demands for oxygen or by inadequate carbon dioxide elimination. So you don't have any gas exchange, basically. So failure is, distress is something that's reversible. Failure is impending arrest, and they're not meeting the demands of things. So signs and symptoms, and this is where you guys are at for the most part, right? You're not, typically when you arrive, you're looking at the signs and symptoms. So in distress, they'll have tachypnea, failure, they'll have marked tachypnea, right? Like they'll be really working hard to breathe. Progressively though, those patients will go apneic on you, right? Like, as kids, you all know that the most common cause of arrest in kids is respiratory arrest, right? So, those kids will actually stop breathing at a point. Respiratory distress, they'll always have an increased respiratory effort, and then progressing to inadequate respiratory effort at some point. In distress, they'll have abnormal airway sounds, they'll be tachycardic, their skin will be pale and cool, and they'll have altered LOC. And then progressing down respiratory failure, they'll be tachycardic, bradycardic late, right? So again, as you're getting to that pre-arrest phase, kids will stop breathing, they'll stop making an effort, and they'll go bradycardic, right? Not unlike an adult who is fixing to die, right? Like, I'm sure you guys have all seen patients in hospital or in your care that, they're circling the drain, working hard to breathe, and all of a sudden they start having periods of apnea, all of a sudden they die. I had one last night, 97-year-old lady that came in, and fortunately she had her code status well intact, and we did some non-invasive stuff on her, but eventually I got called back to the room because she was working very hard to breathe and then just went apneic, right? So at some point you overwhelm your residual capacity and your ability to compensate, and then it just completely shuts down, right? So cyanotic, stupor, and coma is where you go with that, and then eventually death, obviously, and arrest. So criteria for respiratory failure we talked about. So, on laboratory stuff, which you guys often don't see or need to even see, right? Like clinically, they'll be tachypneic, bradypneic, they'll be apneic, and they'll have irregular respirations. And that all just signifies that their oxygen saturations are less than 60. And then you'll get the pulsus paradoxus, which, we used to always, talk about measure. It's not practical to measure, right? Like, we don't measure it in hospital. I can't remember the last time. I don't really care, right? Like, you don't need a pulsus paradoxus to tell you, if the patient's in trouble or not. But, clinically, it's greater than 30 millimeters of a pulsus paradoxus. Decreased or absent breath sounds, stridor or wheeze or grunting, severe retractions and use of accessory muscles, which we saw in those little kids, right? And then cyanosis in 40% when their oxygen level is down to 40%, they're profoundly cyanotic. And then, some people will get agitated, some people will get profoundly, obtunded, and then basically no cough, no gag, poor muscle tone, and obviously I think you guys can figure out that in that scenario they're in a big amount of trouble, right? So that's a kid looking in a mirror there. So we'll talk first about upper respiratory airway emergencies, and then we'll progress on through. So first case is a kid called Allie. So you're dispatched to see Allie. She's a 3-year-old female with breathing problems, according to mom, right? And I'm sure, you guys see this probably. Your pre-arrival information is often not very good, right? Like, you may get some information, but often, dispatch is going off trying to fit the complaints into a card, right? So, you know, it doesn't always line up. The dispatch information that you have doesn't always line up with what you see when you get there, right? So, you know, basically, you know, this kid's got breathing problems. You don't know how severe it is or anything else. So what kinds of things do you guys want to know? Like when you first arrive on scene and start, you know, assessing the situation, what are the key features that you guys are interested in? Okay.
How long has it been going on?
Okay. Yeah. Okay, good. Yeah. Is the kid looking well? Has the kid been sick? Yeah. Yeah. Has the kid got chronic medical issues? Like, are they, you know, do they have some weird syndrome or something like that? You know, immunizations is always an important question to ask in kids, obviously. But, you know, those are kind of the things. So this kid woke up with a high fever, complained of a sore throat, rapidly progressive respiratory distress, now won't talk, won't eat, right? So drooling, no cough. Does the kid sound sick or not sick? Sick, right? Like, I mean, you hear that story, that's very worrisome for, what do you think guys think's going on in this? Yeah, so for certain, this is the one that you think about, epiglottitis, right? So kids not immunized, which is an important, you know, obviously a big risk factor for that, like I said earlier. And, you know, that's what the kid looks like, right? So you look at her, she's got a high fever. She's got a respiratory rate of 45. She's got 93% SATs on room air. Blood pressure's okay. I mean, would blood pressure, wouldn't be a hill I would die on in a kid. I mean, it's obviously nice to know, but, you know, you want to be as hands-off with these kids as possible, right? Because these are kids that, you know, even in hospital, we typically are very hands-off on these kids, and you know, ultimately they need to go to the operating room to you know, be intubated in the operating room, right? So she looks terrified. She's tripoding. She's sitting in that kind of, you know, sitting in that sniffing position. She's drooling. She's got audible stridor and no cough, right? So you guys have already given me the correct diagnosis. So that's what the epiglottis looks like, right? So this is the epiglottis, right? So normally we see it as a, you know, a thin, floppy, especially in kids, a really floppy thing, right? But in epiglottitis, that thing swells up to like a piece of meat there. And you can appreciate, like in this kid, at least you can see, you know, you can see your target at least there, right? Like, I mean, you know, you're going there, right? So in this kid, I mean, you can imagine though, if you were, you know, not that you guys would ever be looking at this or shouldn't be looking at this, but you know, that's what the view is, right? So obviously, you know, big concern from our point of view as far as how to manage this, right? So from your guys' point of view, pre-hospital management, ABCs, keep the kid calm. And the only thing that I would say is, you know, consider an EpiNab, right, on these kids, right? Just with a, you know, 5 milligram of 1 in 1,000 nab, right? And just put that on the kid, or even have it blow by or whatever, right? And then obviously if the kid's got impending respiratory failure, you may need to bag valve mask and plus or minus a definitive airway, right? But obviously this isn't really the kind of kid that, you know, we're thinking about electively intubating, even in the emergency department, right? These are kids, the kid shows up like this, looks like this, we do as little as possible. A phone call to the operating room, the anesthetist and the ENT surgeon, and say, you know, this needs to come up now, right? And needs to be mobilized, right? And the only thing we would do is maybe slap an EpiNab on the kid, right? So this is your guys' algorithm for respiratory failure, right? So in your scope, you have EpiNabs. If you suspect croup, then you'd give Dex, right? And then if ventilatory support required with bag valve mask, an advanced airway requirement, treat concurrently with the pediatric airway protocol. So I mean, I think in your guys' protocol, basically you guys are bagging patients into the hospital at this point, right? There's very rare that you would be doing anything beyond that, right? And there's a reason for that, right? I mean, number one, you know, kids' airways, I'll show you a slide a little bit later on just about kids' airways and success rates of even like residents rolling through, of how well they manage those airways. And number two, just, you know, overall experience, right? Like, I mean, you know, we just don't see a ton of kids. Even in the stollery, there's very few kids that present that are ever intubated, right? It's just not something that's very commonly done, right? Like even in a tertiary care emergency department, anything procedurally is very rare. It's just the nature of the beast, right? So, you know, everybody's experience, whether you're a physician, paramedic, is limited, right, on live breathing patients. So obviously, you know, you don't want to be this being your first rodeo, right, doing something like this when it's something that's, you know, if kid arrests and you can't deal with, you know, the airway, and it's a disaster, right? So I don't think you really want that hanging around your neck. So less is more in epiglottitis, obviously, in the pre-hospital world and in the emergency medicine world, right? We do little for those people other than keep them calm, leave the kid with their parents, like do everything you can to keep that situation and the kid calm and under control, right? So minimal handling, unless absolutely necessary, no IV, right? So these kids typically, if they go up to the operating room, it happens all quite quickly, right? Like they'll be induced with like an anesthetic agent, and then they'll start the IV. Like they'll have multiple people. Somebody will start the IV, and then they'll do it all. But typically, they'll induce the kid, and everybody's standing by, ready to roll, right? So it's obviously, like I said, it's a feared pediatric emergency. I said earlier, it's decline in incidence because of the influenza, Haemophilus influenza type B vaccine that kids get now. You guys can appreciate from the picture I showed just the inflammation, edema of the epiglottis, arytenoids and supraglottic tissues, and the typical age range is in that 3 to 7 year old age range of kids. That's what they look like on X-ray. So this is called, like, the arrow points to that's on a normal X-ray. The epiglottis looks like you would think it would look, like it's just a thin little stripe, right? But if it's thick and fat like that, and it looks like a thumbprint there where it's sitting, that's what it looks like on X-ray, right? So, and then you got the, you know, air in the hypopharynx and no air beyond that typically, right? So what do we do in the emergency department? So we continue the minimal handling, urgent ENT, if impending airway obstruction, ENT plus or minus anesthesia plus or minus surgery, and they may require a crike or a transtracheal jet ventilation, right? So, I mean, that would be worst case scenario for us, but typically we'll mobilize things very quickly, and that's something we'll get, like, you get a quick response for that if it needs to be. Any questions about epiglottitis, or?
Is this like closest hospital emergency, or is it better for us to take our time to get to the stall?
I'd take them to the stollery. There's no point in, like, it's like like, to me, that's, yeah, I mean, there's nothing is going to be done for that. You're going to just end up standing by and transporting. You're far better off to move to where there's definitive treatment for this kid available, right?
So like an antiviral or like antibiotics, start them?
No. No. I would move, because what's going to kill this kid is not the infection that caused it. What's going to kill the kid is airway arrest, right, and respiratory compromise. So, like, I would, if that's your suspicion of what's going on, and the kid looks that unwell, and you have this story of no immunizations, I'd be moving to the stollery, right? You know, like, again, minimal handling, right? So once you have them in your ambulance, the extra 10 minutes of driving is not the make it or break it thing. the unloading, loading, unloading, loading is far more traumatic, and lots of different people looking at this kid is probably far more traumatic for the kid. So case 2 is little kid Mikey, we'll call him. So it's the middle of the night. You get called to see Mikey. He's an otherwise healthy 2-year-old with trouble breathing. That kid looks older than 2. I don't know where I got that picture from. He looks 4 to me or so. He's precocious, I guess. So this kid was well during the day. He woke up with a fever at 2200 and then woke up at 0200 with increased work of breathing, inspiratory sound, and a barky cough. Sister is also sick. Kid's got a fever of 38.3, tachypnic, respiratory rate of 44, SATs of 94% on room air, blood pressure 92 on 56, and a heart rate of 133. So I mean, I've kind of listed the vital signs in kind of the order that I would think are of importance, right? To me, eyeballing the kid, you don't have to do much to get a respiratory rate. You know, you put a SAT probe on the kid, you get that information, and you know, plus or minus a temperature, right? Most of the time you'll appreciate that they're warm or whatever, they look febrile but this kid's got audible stridor. He's got tugging, indrawing, and the classic barky cough, right? So, you know, you guys have all seen croup in your careers, I'm sure, at some point or another. My twin brother actually had croup as a 20-year-old, and I just remember finding it totally hilarious that he woke up and he had I mean, I was not in medical school yet, but he had the terrible indrawing and retractions, and he was like panicked, right? But it was like, I found it funny, but that's because I was his brother. But yeah, so you can get it, like people can get it typically, but typically the age range is, you know, that young group, right? So we've already talked about what the diagnosis is croup. So what's pre-hospital management? So we've already touched on this a little bit, right? So ABCs again, epinebs, 5 milligrams PRN, and then Dex. So typically for you guys, 0.5 milligrams per kilo, PO or IV, max dose of 8 milligrams. Most of these kids will tolerate PO. I don't know what your experience has been. You probably rarely start intravenous on these kids, I would suspect. Most of the time it's nebs and PO Dex, right, from your guys' point of view. Is that correct, or would that be a fair statement? Or so again, this is your algorithm that you guys use. So epi, Dex, and then obviously, you know, you're going through signs of respiratory distress, signs of failure, right? So you're always looking at those things, kind of going through your checkbox. I'm always like, the protocols are actually fairly well written. I think as far as a good reference for you guys to quickly look, and I pull it up occasionally. Like, I have your app on my phone, and I actually find it quite, like, 'cause sometimes, like, if I'm doing an OLMC or whatever, I don't always remember like all the, you know, what you guys have in your scope as far as what's available to you guys. So it's easy for me to pull it up and look, and I actually like it. I show it to the residents all the time, and they're like, "Oh, that's pretty good." Like they like it. A lot of them will download it, right? Because for common emergencies, those protocols are actually very, very good, and they're a good quick reference, right? So I find them useful for, you know, nothing else. So if you think it's croup, you give Dex early, right? And why is that? So there's been multiple studies that have shown it reduces time in ED and reduces return to ED and decreases our use of epinephrine in these kids, right? So it's helpful, right? So earlier you get it on board, the better it is, right? I mean, it's not, I think you guys all know that, you know, steroids take time to work, but it's been shown in multiple studies, and in the Cochrane collaboration, which is a systematic review of it pools numbers of studies. It's been shown over, like, pooling all those things and looking at like multiple studies. There's a definite benefit to giving early steroids. It decreases time in hospital or time in emergency department, decreases admission. So, I mean, obviously it works. So if a child with croup needs epi, they'll also need Dex, right? So We typically give both to these kids if they're severe. So we'll talk a little bit more about croup scores and that kind of stuff as well. So it's the most common upper airway disease that you see in kids. So the age range is 6 months to 6 years, typically caused by parainfluenza type 1. So you get inflammation, exudate, and edema of the mucosal and submucosal tissues in the subglottic space. So that's why they get that stridor, right? So that's why they get that barky cough. That's why you get, and I mean, it's a very characteristic cough, right? Like, I mean, you hear the kid, when I'm working, you'll hear the kid cough, and it's like, before you even go see the kid, the diagnosis, right? So it's one of those things that, typically, kids they don't look typically terribly unwell, right? They're brought in by their parents because they have this barky cough and they woke up in distress, right? So obviously most patients, often that we see, they resolve by the time they get to emerge because they've been exposed to cold air. Often they've had decks by you guys, or if they haven't, or if they've brought in by private vehicle, then certainly we give them decks very early on. And the nurses are pretty good. Like, if they know that the kid's got croup, they'll come to us early, even if the kid's in the waiting room, and say, this kid's got that barky cough, can we give him a dose of dex or whatever, and we will. So they may require repeated epi-nebs. Very few kids, like I said, need admission, right? So, and very, I would say the number's probably even lower than that, but 1 to 2% from the literature says they need intubation, right? But very uncommon scenario that we would see. So what are the indications for admissions? Which are the kids that would actually get admitted? So severe respiratory distress or failure. And again, this is a very small subset of the population. So unusual symptoms, hypoxia, hyperpyrexia, like if they really high fever. Most of these kids have a low-grade fever, but they don't have temps of 40, right? They're dry. That's probably the most common reason why. They're just not tolerating oral intake very well. Or persistence of stridor at rest after aerosolized epinephrine and steroids. Persistence of tachycardia, tachypneic, complex past medical history, right? That's probably the factor of the kids who are got, other comorbid illness or congenital issues. Those are the ones that typically get more in trouble or more concerned that they're going to have an issue, right? So prematurity, or if they've got pre-existing pulmonary issues or cardiac disease, those are the ones that typically we would say that would get admitted, right? So any questions about croup at all, or thoughts about that? I think, again, probably one of the more common things that you guys would see as far as any respiratory emergencies. So next one is Ricky is a little 12-month-old female, otherwise very sudden onset of respiratory distress. So previously well, no fever, no cough. Mom left her playing with her older brother and his Lego toys, came back and found her drooling and having trouble breathing, right? So you show up, the kid's got kid looks well, they're drooling, they've got audible stridor, weak cough, minimal air entry on auscultation, there's, they're tachypnic, got 96 sats on room air, but they otherwise look okay, and they were well prior to this. That's probably the biggest thing, right? So, often they'll present as with a wheeze or whatever, right? So what do you guys think's going on here? Yeah, so foreign body, right? So this kid's got a foreign body in their airway. So pre-hospital management, right? So ABCs, consider ALS intercept. Is it partial or complete, right? If it's a partial obstruction, typically you guys aren't going to do much of anything, right? If you're just going to transport that kid. Yeah. So, but if it's complete obstruction, then we go to back blows, abdominal thrusts until successful or until the patient's unconscious, right? So in an infant, we're talking back blows, right? If the kid's in stop breathing, if they're oxygenating, moving air, you allow them to maintain their position, continue coughing. If they have poor gas exchange, ineffective cough, severe distress, cyanosis or stridor, you do your back blows if they're less than 12 months, right? or the Heimlich if they're greater than 12 months. If they're unconscious, then we go to the chest compressions, right? So this is basic BLS CPR stuff, right, is what we revert to. And I have the case like this in the I do the majority of the exam prep for the 5th-year residents in the residency, and I have a case in there just where it's like, it's amazing, because when I was a national examiner for the specialty exam in emergency medicine, it's amazing how poorly physicians do basic, just because it's not in our realm. Like, typically it's done before they get to us, right? Like, you guys have typically solved those problems by the time they present, but you present this situation to a physician and they do basic CPR and basic BLS type stuff very poorly, actually, right? Because it's just not in our realm, right? So I have a case that I give, and even at the national exam level, I remember one year there was a case and a number of the residents failed that station or whatever on the oral exam because they didn't do like basic BLS type stuff, right? Like they completely jumped over it and were doing other things, and it was like, no, you gotta go to basics here first, right? So this is your guys' airway or algorithm again, right? It doesn't project terribly well, I don't think, for you guys. It's pretty readable. So again, talking just about, algorithm for you guys. If it's partial or complete obstruction, they're cyanotic, then you do the abdominal thrusts, back blows, chest thrusts until successful or patient becomes unconscious. And then once they're unconscious, then it's chest compressions, clear airway, attempt to ventilate, and then, typically you're looking at that point of direct laryngoscopy and looking to see if you can remove the foreign body, right? And I don't know if you guys know the history of paramedicine in the region, right? But one of the biggest impetuses for within, it wasn't always that there was ALS service and the level of sophistication that EMS has reached over the last 20 years or so, right? I mean, the whole reason why paramedicine came into being as opposed to ambulance drivers in the region was sparked by an incident in Strathcona County where there was a child that died because they choked on something, and the kid, I mean, basically it was an airway obstruction, and had that kid received timely care in the pre-hospital arena, the kid would have survived, obviously, right? But the kid died in Strathcona County, and it was one of the big motivators, certainly in this region and in the province, to move towards EMS and EMS level care. So I don't know if you guys know that little tidbit of history, but that's my history lesson for today. So that's one of the biggest reasons why things progressed for EMS in the province. So in small children, always keep foreign body ingestion on your differential for sudden onset respiratory distress, obviously, and it's a common cause of asphyxia in small kids. So in the emergency department, we would continue the Heimlich or chest compressions. If there's no chest rise, do direct laryngoscopy, remove the foreign body with McGill's forceps. The life support measures may dislodge. If not, then what we would do, like if you can see it but it's sitting in the cords, you can't get it out, we'd push it down, right? So you push it down, right main stem, typically you'd hope it would go, and then pull the tube back, right? And then obviously you're going to need to go fish that out, right? But in the main, like in the immediate short term, we're looking to keep that kid alive, right? So that's what would happen. So you look, you can't retrieve it, or it's beyond the cords, you can't get it, intubate, push it right main stem, withdraw the tube, at least you can ventilate the left lung then, right? So common cause of death, so food items are the most common, non-food items is the other percentage. Those don't add up, do they? 48 should be 48, 42, or do they? Oh yeah, I guess they do, my math is poor. So hospital mortality is 3.4%, and usually if it goes down, it goes into the right main stem, right? So these kids need to be, like in hospital, if you knew that it was a foreign body, a lot of times if it's radiopeg, it'll be visible on x-ray, but those kids will need a formal bronch to pull that out. So what's the differential for stridor, right? We've talked about one of them is croup, one of them is epiglottitis, one of them is foreign body. The other things that can cause it, you can get retropharyngeal abscesses, bacterial tracheitis, laryngomalacia, which is a congenital thing, right? And tracheomalacia, again, another congenital thing, right? So, I mean, the three top offenders, though, or the three things we always think about immediately are croup, epiglottitis, foreign body, right? And then abscesses or infections are on that list as well. Any questions? Yeah, kid. This is safe. That's a good car seat there. So we'll talk a little about lower airway obstructions, right? So when we talk about upper airway, we're looking at nasal cavity, pharynx, larynx. The lower respiratory tract is trachea, bronchi, and lungs, right? So lower part. So case 4 is Mandy. So Mandy is a 5-year-old female. Mom has been called because she sounds wheezy. So history, she's got cold symptoms for the last 5 days, runny nose, cough, fever. She's using Ventolin every hour without relief. Today, increased work of breathing, shortness of breath, history of eczema, allergies, and asthma, right? So those are the things, you know, that atopic history of eczema, allergies, and asthma is typically, you know, what we're looking for. But so this kid's using their Ventolin very frequently. So on exam, you know, this kid's respiratory rate, again, tachypneic. So again, you can learn a lot just by looking at a kid's respiratory effort and looking at a kid's respiratory rate, right? So just effort and rate, you can tell a lot about, you know, how good the kid is, or how well the kid's doing, or how poorly they're doing, right? So 92% on room air, blood pressure is okay, pulse is 135, temps 37.8. She's got loud expiratory wheeze that you hear from the door. She's got a tracheal tug. She's indrawing. She's got diffuse wheeze and minimal air entry on auscultation, right? So does this kid sound like they're in trouble with their asthma? Certainly do, right? Like, I mean, if you see a kid working that hard to breathe and they're not moving much air, that's pretty significant, right? So reactive airways, right? So most likely asthma in this kid, right? So pre-hospital management, again, ABCs, Ventolin, Atrovent, and then obviously in your guys' armamentarium is mag sulfate, Dex, Epi, like Epi nabs, or even I think we'll look at the protocol after, but I'm pretty sure you get down to IM Epi or something like that. I think you treat it much like an allergic reaction, and then continuous Ventolin, obviously, right? So in hospital, I mean, you know, if this kid arrived and you guys haven't given the mag, we'll typically give the mag. You know, certainly if the steroids aren't on board, we'll give the Dex, right? But in a kid like this, you know, they're in real significant trouble, right? So your algorithm goes, you know, so this kid would be moderate to severe impending respiratory failure would be the path that I would put this kid on, right? Because they're in significant distress, right? So salbutamol, and then Dex, and then Epi-IM, right? So again, low dose, 1 in 1,000, 0.01 milligram per kilo IM. So single maximum dose of 0.3 milligram per kilo, or 0.3 milligrams, and then total maximum 0.09. So, or 0.9, sorry. So, again, that's treating it more like, you know, down the anaphylaxis allergic reaction thing, but I mean, ultimately, I mean, it's Epi's beta 1, beta 2 effects, right, is what we're looking for there. So, if their condition does not improve, then you guys progress to mag sulfate, and salbutamol, continuous nabs, right? So I can hospital this kid, if they showed up like this, they'd just be on continuous nabs of salbutamol, right? And then we'd be doing all the other stuff in concert, but certainly they'd be getting that going down. So how does,
Can I just ask a question?
yeah,
What's your thoughts about doing respiratory peak flow? It's still very shy, it's hardly ever seen over here.
Yeah.
I've been here 16 years, it's still very rare to see.
yeah,
15 years back in the UK, that was standard of care.
yeah,
The hospital, so we peak flow them.
yeah, like do it pre-treatment, you mean? Or, I mean, in hospital, I think part of it is, practicality of doing it, and just like to have peak flow meters and all that stuff that, I mean, typically like they'd have to be disposable, right, in your guys' arena. What's that?
Single patient, single use.
Yeah. And so I think like in our, like in hospital, a lot of these patients, if they arrive, they will get like a pre-treatment peak flow, and then we'll follow it, right? Because it's a good way for us to predict outcomes, like how they're going to do, if they're going to be dischargeable and that kind of stuff. And often respiratory, that's part of their algorithm when they do stuff, is they'll do peak flows on people pre-treatment, post-treatment, and that kind of stuff.
A long time ago, when you saw those numbers, you have a good appreciation of patients that are in moderate
Yeah.
signs and symptoms.
Yeah.
Because as we all well know, kids mask it so well.
Yeah.
But as soon as you see the peak flow, or the lack of it,
Yeah.
then that, as a practitioner, gives us...
Yeah. The problem with doing peak flows is they have to be done correctly, for one, right? And so you have to have, like in kids, they're not terribly practical, right? Because kids typically they don't understand what you're trying to explain for them to do, right? So that's one limitation, particularly in pediatrics. And then I think in adults, like if you're talking about doing it in adults, typically, just the practicality of doing it in the pre-hospital world is probably what's limited it more than anything, because it does provide some valuable information as far as where they're at. But a lot of it you can gauge to a degree from their clinical exam, right? So when you guys talk about that moves well into this, right? So how do you guys classify bronchospasm, right? So if they've got no indrawing, if they no retractions, just expiratory wheezes, that's probably, most of you guys would appreciate that that's a mild asthmatic, right? But once they moved on to indrawing, retractions, they've got inspiratory, expiratory wheezes, or, a very silent chest, then you know that they're in trouble, right? How many of you guys have seen somebody who's arrested from asthma? Yeah. It's not, again, it's we see it probably less frequently, but some of the most dramatic things that I remember from in my clinical practice over the years is, the asthmatic that arrests, right? Because they're, you just know that they're circling the drain, and then all of a sudden they just stop, right? So how do we, if you had an asthmatic that arrests, what do you do? Like, how do you guys manage that? It's a good little segue into that. Any thoughts? So all of a sudden they're breathing, not breathing. What do we do? Yeah. Okay. So airway. So how do we ventilate those people once we have the airway? Right. So you want a long expiratory phase, right? And even a forced expiratory phase, right? So you're going to really help those people, like even if it's manually helping them exhale, right? Because typically they have air trapping, right? And a lot of the reason why they arrest is because they've auto-peeped, right? So they've basically breath stacked to a point that their venous, because their interthoracic pressure is so great, their venous return has basically been eliminated, right? So they've got no venous return. And as a result, they've auto-peeped themselves to the point where their blood pressure's tanked, and they have no venous return to the heart, right? So, typically fluid, ventilate them appropriately with long expiratory phases. If they've arrested on you, we'd bilaterally decompress them too, right? Like, because in essence, like if they've arrested, you're looking for reversible causes, right? So what are the reversible causes, right? One of them would be a tension pneumo, right? So we would just bilateral, if they've arrested on you, we'd bilaterally decompress these people, and then put chest tubes in them, right? So that's kind of, again, that's kind of the algorithm that, we roll through in the emerge if something like that were to happen, right? And I've had, I think 2 times I've had a guy that, arrested, again, showed up, is known, like previous ICU admissions with his asthma. He gets wheeled in by his family, put on the stretcher, and as soon as he's on the stretcher, he arrested, right? And then it's like, okay, well, game on, right? So no such thing as too much Ventolin for an asthmatic, right? So I mean, if these guys need continuous nebs, that's where we go. So if your 3 or 4 Ventolin Atrovent nebs haven't worked, but the patient's the patient's still in distress, consider continuous Ventolin on these people. So ultimately, last thing we want to do is intubate these people for the most part, right? So what are the side effects of Ventolin, right? They get tachycardic, they get shaky, and they get potassium shifts. So, I mean, we monitor the potassium, but they're, ultimately, you need to treat their disease. My daughter, when she was about 3 years old or so, I was working the string of nights, and I don't know how many, I'm sure a lot of you are married, but my wife was telling me that my daughter was in, she was having real trouble breathing, right? And I was in the string of middle of the nights, and I'm like, whatever, yeah, she's fine, right? So of course I go to work, and then I get the call that, she's gone to the stollery, and she's being admitted to the ICU, and I was like, okay. So, yeah. So, I mean, she was in ICU, but, Jay knows my daughter because he coached her and stuff. But when she was a little kid, she was quite pretty perky little thing, and I just remember her being in ICU, and she was on IV ventilating. She was on IV Ventolin, and she was absolutely vibrating because she was just so, like, her heart rate was like about 150, right? And she was just like, I think she was about 2 or 3, like just barely talking, and she was in the ICU, not intubated obviously, and anytime somebody walked by the door, she would just go, "Hi." She had a hoarse little voice, "Hi." It was quite funny anyways, but yeah, so it's, I mean, yeah. So so HS has an Alberta-wide protocol for pediatric asthma. So we score children using the PRAM score from the protocol. Like it's part of your guys' protocol. Yeah, go ahead.
What are your thoughts on MDIs versus like side streams and stuff like that?
Well, in kids, I mean, again, MDI has been shown to be equivalent to side stream nabs, right? The nice thing about MDIs is that, it's easy to administer. The compliance is generally good, right? Because you guys just hold the aero, you pump it in there and just hold the aero chamber on, right? So, I mean, the nice thing about them is you don't get all the aerosolized stuff kicking around, right? Like, I mean, there's been a conscious decision made to use MDIs as opposed to aerosolized stuff, just because of the infectious risk of aerosolizing stuff, right? From your guys' world and even from our world, right? So, I mean, if we can in hospital, we'll typically use MDIs and inhalers, but occasionally we'll need to use nebs, right? But so you guys should have seen this or be aware of this, but the PRAM scores, if you look, I mean, again, indrawing, retractions, wheezing, air entry, and oxygen saturations are kind of the main components of that, right? So, I mean, this is the AHS acute child asthma pathway, which is evidence-based. So, one of the big, I mean, one of the guys at the U, Brian Rowe, is a big researcher in croup and asthma in kids, right? And he's one of the guys that was part of the Cochrane collaboration, which again looks at does systematic reviews with all these things. So he's one of the experts actually in Canada and probably in the world with looking at all the evidence regarding all this stuff. So a lot of this is where this stuff comes from. So again, it just gives you an idea of where somebody's at, right? I think you guys can all appreciate you guys can all appreciate when somebody's really sick, with asthma and where they're at, but you know, it's particularly when they've got impending respiratory failure. I don't think there's too much debate about what's going on at that point. So treatment in the ED, Atrovent, Ventolin, continuous Ventolin nebs, MAG and steroids if they haven't been given. If they're getting worse, then we would consider BiPAP on these kids. You know, again, attempt to avoid intubating these kids, right? Because with all the complications of intubation and everything else, and then IV Ventolin. We don't use IV Ventolin so much in adults. You know, it's more a phenomena, I think, in peds ICU. And I don't know what the evidence around IV Ventolin is, as opposed to putting them on or giving them, like if you're having to give like systemic drugs to treat it, like giving like EpiIM is probably as equivalent as giving IV Ventolin, right? Because IV Ventolin is basically a beta agonist, right? So it's not, again, the evidence around IV Ventolin is probably suspect, but it's still used primarily in the peds ICU world, right? It's not something that's ever used in the adult ICU world, quite honestly. It's more of a peds ICU thing that they've done for years, right? So again, asthma is a lower airway disease marked by bronchoconstriction, mucosal edema, pulmonary secretions, you know, very prevalent, right? So population of the US is what, 30 million or 300 million, I mean. So 7 million people in the US have asthma. So it's one of the few chronic diseases of childhood with increases in prevalence, morbidity, and mortality. And obviously, I think you guys know common triggers are upper respiratory tract infection. So normal airway looks like that. An asthmatic airway, you know, when they're having an attack, they, you know, smooth muscles tighten, you get air trapping, and so that's what their airways look like. So mag sulfate is thought to work by being a smooth muscle relaxer, right? That's why mag is thought to work. So that's that. Any questions about asthma or comments or thoughts about that? Or good? Right. Again, probably, you know, croup, asthma, probably the two big highlights for you guys as far as what you guys would get called to treat, right? So case 5 is a little girl, Anna. So dispatch has sent you to see Anna, an 8-month-old with trouble breathing. So cough and fever for 4 days, increased work of breathing today, not eating, only 2 wet diapers in 24 hours. Mom reports periods of apnea, premature but fully immunized, right? So number one, you know, you see that story of apnea, and that's very concerning, obviously, right? So, or even that report of that is very concerning, right? So on physical exam, this kid's got a temp of 38.9, heart rate of 150, respiratory rate of 60, SATs of 82% on room air, 88% on non-rebreather, so still hypoxic on a non-rebreather. Kid's head is bobbing, retractions, tugging, crackles and wheezes, and kid has 2 apneic periods while you're there, and you have at least a 30-minute transport time. What do you do? So first of all, what's the diagnosis? This kid's got bronchiolitis, right? So pre-hospital management, ABCs, kid's got impending respiratory failure, you know, probably a need for intubation. When in doubt, call OMC, right? So what are some of the anatomic and physiologic differences between adults and children, right? So this is a common thing that you guys go through in your schooling and everything else, right? So even though it's a rare event, I mean, occasionally it's necessary, right? So large head, right, relative to their body, right? They have a prominent tongue. Their laryngeal inlet is cephalad, right? So it just means their airway is quite anterior. The cricoid ring is the most narrow portion of the airway. They have a floppy epiglottis, and they have decreased functional residual capacity, which all means that, you know, your time before they desaturate and everything else like that is much lower, right? So when they have a high proportion of vagal innervation, which means that if you start messing around with their airway, a lot of these kids will get bradycardic, right? So how do you choose ET tube in pediatrics? What do you guys use as your little formula? Everybody's got a different way to size it or measure it. What's that? Good. Yeah, that's good. That's a good answer. That's my answer. Okay, what else? There's other ones that you can use. Nostril size, yeah, that's one. The other ones? There's a formula. You guys remember that one? So age over 4 plus 4 is uncuffed. Age over 4 plus 3.5 cuffed. And then diameter of the 5th digit nail, right? I like the nostril one, right? That's an easy one to do, right? You can pull out a tube and put it in the kid's nostril. Okay, that works. That's an easy way to do it. If you're, I mean, that's the one I would probably rely. I wouldn't be relying on my math skills if I'm dealing with a kid that's you know, impending arrest. I think the best one is probably the Broslow tape, right? Like, I mean, honestly, if we get notification, like pre-hospital notification that a kid's coming in, you know, because we do see it at the ALEC even, because, you know, they'll go to nearest hospital, right? So if we see kids like that, they're generally like really, really sick. So, you know, first thing I do is lay out the Broslow tape. Like, I don't want to be relying on my math skills and recollection of you know, in something that I do very infrequently in my practice. And just being honest, I mean, for me, it's far easier to lay out the Broslow tape and just have that available for me to look at and reference to for everything, like dosing, you know, equipment sizes, for everything, right? And then there's no errors made. It's a quick reference, and it's a good way to do it, right? And that's, I mean, I would suggest that that's probably the best way for you guys to do it, because when you're in a scramble in that kind of a situation, the last thing you want to be doing is like, you know, trying to remember, like, okay, what, you know, what's the dose or whatever, right? It's far easier to just refer to that. So again, depth of the, once you've intubated them, depth, age less than 2 plus 12, right? Or age over 2 plus 12 in centimeters. So in kids, I mean, we often talk about pre-medication with atropine. I think PALS has actually moved away a little bit from that at this point. But certainly if the kid becomes bradycardic, you would give atropine on a pure weight-based dose, right? So I don't think there is a true some of you guys, have you done PALS recently, anybody? Or I don't think there is a true minimum dose anymore. That it's strictly based on weight, right? So, and then, what's that?
New guidelines are getting older, so if you see
Yeah, I'm just trying to, I think I've seen some of the new recommendations or whatever, and I think it's purely weight based. So, and then some controversy regarding succinylcholine in pediatrics, right? Because the kid's got undiagnosed muscular dystrophy, there's a potential contraindication to using sucks, right? So, I mean, a lot of people would just use rock in these kids. If you made the decision to intubate, we'd probably just go to rock. So, obviously in the emergency department, if they're intubated, PICU admission, supportive care, may try Ventolin, Epinebs, hypertonic saline, right? So bronchiolitis is one of those things that the literature regarding Ventolin and Epinebs is controversial, right? Like, does it work? Doesn't it work? So it's contradictory. There's no true consensus on using Ventolin and Epinebs in these kids. Typically what will happen in the emerge is we'll trial it, right? If it's successful or it works, then we'll carry it on. If it doesn't do anything, then we just say, okay, like, we don't persist with it, right? And that is oops, that's from like a Merge Medicine textbook, right? So bronchiolitis, acute infectious disease, result in inflammation of small airways in children less than 2 years old. So typically these, you know, the ICU will be packed with these kids, right, in that certain time frame. When there's a bronchiolitis outbreak or whatever, and the ICU will just be packed with these kids. So, and it's mostly due to RSV, right? So a lot of these kids will present, we'll see them, they're in respiratory distress, they'll get a nasal swab sent for RSV just so we know what's going on. And a lot of these kids, particularly if they're having academic periods, those kinds of things, I mean, obviously they get admitted, right? And there's There's accounts for 1 in 5 acute care hospitalizations for children less than a year old. So that, when you think about it in the grand scheme of things, that's very significant, right? Like 20% of the admissions in that age group are because of bronchiolitis or RSV, right? So differential diagnosis again for wheeze. Talk about asthma, bronchiolitis, pneumonia, obviously. Reflux would be on the differential, congenital abnormalities, and anaphylaxis, right? Pulmonary edema, and that's it. So, from whenever I'm approached with a problem, we always think about differentials, right? Like we're always thinking, we have a pretty good idea what's potentially causing things a lot of times, but we always think, okay, differential, is there a reason why this kid is wheezing, right? So we think, asthma, bronchiolitis, pneumonia, reflux, all those things kind of enter the realm of possibility, and obviously we narrow them down and make a formal diagnosis on these kids. But any questions about that at all? So let's talk a little bit about lung disease. You guys need a break, or you can take a quick break if you want? Good to go. Am I hitting the mark here? Or is this no good, or is it all right? Or okay. I think it's far more interesting to kind of go through at least somewhat of a case-based approach, anyways. So this is one. It's a 14-year-old with a 1-week history of cough, fever, shortness of breath. EMS is called for increasing respiratory distress. So he's more, once a kid's 14 years old, they're behaving like an adult, right? So 1-week history of increasing shortness of breath, fever, productive cough, no history of asthma, has never needed inhalers, increased respiratory distress today, previously healthy. So what do you think about? Physical exam, he's got a temp 38.9, he's got SATs of 89% on room air, 96% on 2 liters, crackles throughout, far worse than the left, moderate work of breathing, fine wheezes. Get him to sign the cancellation sheet and off you go. What's that? Yeah. So diagnosis, what do you guys think's going on there? Yeah, exactly. So pneumonia, yeah. So pre-hospital management, ABCs, oxygen as needed, IV fluids, plus or minus Ventolin, right? He's got some wheezing there. Are you going to do any damage by giving Ventolin? No. So again, your guys's, you would term this influenza illy type picture, right? You don't have a chest x-ray showing you that this kid's got a pneumonia, but certainly, the kid sounds sick, right? He's got a fever, he's tachypnic, he's hypoxic. There's not much that you need to, other than looking at his vital signs, that to determine this kid's sick, right? So, even if he looks well, he's got deranged vital signs, right? So, any illy type patient we always think about, and I don't know how much you guys know about the last last influenza season, right? But some of the most severely ill people were young adults, right? That were sick enough that obviously were intensive care, and some of those patients actually got put on ECMO, right? So they were sick enough that it was like in a bad way, and there were several deaths, right, in the province and in the region from influenza-like illness, and affecting those young people. So what's the number one moral of the story? Get your flu shot, number one. Encourage your friends and family to get your flu shot, right? Because I guess I'll say I don't really get the whole anti-immunization thing in the whole world right now. A lot of it's based on misinformation, and I'll just leave it at that. I don't know how many people have read, obviously the whole immunization theory behind autism has been debunked, right? But there's something that came out that actually think makes a little bit of sense and could be, I mean, autism, I mean, this is totally off topic here now, but autism in general, there's a study that's being presented that they think that there is a link between autism and people who are on megadoses of folate and vitamin B12, right? Which makes sense, right? Because people have been advised to take megadoses, or not megadoses, but take folate to decrease neural tube defects in pregnancy. And that's a phenomena that's been over the last many years, right? And, you know, when I was a kid, was autism even a real, I mean, we always had weird kids in our class, right? But it wasn't like a formal, like now it seems like tons of kids have autism, right? Like true autism spectrum disorder, right? And you wonder why that is, right? So there has to be some kind of, you know, you always think, is there some kind of, something's changed, obviously, right? So a lot of people hung it on immunization, right? Which has been disproven, but I think there may be some merit. I think I just read in the paper, like this is, it's being presented, I think, at some autism conference, but somebody has studied, and it looks like there is a significant link between, you know, people whose B12 and folate levels are super therapeutic, which makes sense, right? So, well, at least it makes some, you know, I believe that. Like I kind of think that's a possibility, right? Like it's certainly something. Anyways, it's totally off topic, but. So if you suspect a pneumonia, but the child is wheezy, I mean, give him Ventolin. It's not gonna do anything or change anything, right? So again, minimal harm to giving Ventolin. So you actually may help their oxygenation by opening them up a bit, right? So what do we do in the emergency department? These kids would get a chest X-ray, or anybody would get a chest X-ray, they'd get fluids, early IV antibiotics, right? And then, you know, we'd obviously pan culture them as well. We do blood cultures, urine culture, and do nasopharyngeal swabs, particularly looking for influenza and those kinds of things. So that's what a severe influenza chest X-ray looks like, right? So treatment-wise, these guys would be getting, you know, they'd be getting the Tamiflu as well as IV antibiotics. You'd treat both. So inflammation of the lung tissue secondary to infection can be caused obviously by bacteria or viruses in 60 to 90% of the time. And 3/4 of the deaths in pneumonia are due to bacterial infections. So I like that one. Baby oils me. So any questions about that at all, or?
What's your thoughts on the adjuvant pneumonia and stuff like that?
Well, again, I mean, minimal harm, right, to using those agents, but, you know, are you, like, specifically, what are you thinking?
Just going with the comp event because you're, like, not 100% sure of
Yeah,
the
well,
underlying diagnosis, right?
yeah, no, that's fair enough. Yeah. So what did we talk about? We talked about key historical physical exam features, pediatrics. We talked a little about respiratory distress, respiratory failure, and then we talked about a bunch of different causes of upper airway, lower airway, and lung respiratory emergencies. References, and that's it. Any questions or discussion around that at all? You guys have any thoughts or anything else? Go ahead.
What are your thoughts on like what they call the LTs calls, I guess we get or whatever? I
Yep.
remember Dr. Sue from years back threatened to murder us in our sleep if we ever left him at home. We never really got a clear picture of what that encompassed. It was basically just, you know, like mom was scared enough to call the ambulance.
Mm-hmm.
I would find myself in those calls all the time. I just put to the hospital.
I'm glad you asked.
Lots of parents are going always coming to spend. Oh, is that the next?
That's my next.
As a presentation.
Yeah, I'm ready to roll. I got a full answer to your question here. So I mean, this is something that I don't think is really well discussed in the pre-hospital arena. I mean, I remember when we first talked about this a few years ago, the whole reason for you know, talking about ALTIs was there were several cancellations on these young kids because EMS would show up, the kid looked fine, and EMS would cancel, and then there were some bad outcomes, and there was no real awareness in the pre-hospital world of acute life-threatening events in kids, right? So that's why Sukram et al. And me and a few people were like, okay, well, this is obviously an issue. There's a gap in knowledge about what an acute life-threatening event is in kids. And, so that's why there was some education done around it at that time, and just some awareness, because at that time, and I don't know if it's made, more progress so that it's on your guys' radar at this point, as far as what it involves or what it is. But, certainly it made the appearance several years ago because of, just the lack of awareness on EMS part and leaving these kids at home. And then, something happens and then the kid, either presents to a hospital and then they give the story, well, we called the ambulance and they didn't take us or whatever. And then, obviously pediatricians are pretty anal people, so that progresses to a complaint and everything else, right? So that was supposed to be a joke that pediatricians are anal, but anyways, it's a real phenomenon. So we'll go through it. I mean, I've got a presentation that I did, in 2012 at St. Albert, but it's a good, thanks for the question, because it stems nicely into this thing. So what is an ALTI, acute life-threatening event? I'll give you your $20 later for the plant anyways. Yeah. So it's an episode that's frightening to the observer, and it's characterized by some combination of apnea, color change in muscle tone, choking or gagging, right? So we're talking about, this is the actual definition. So it's an episode that is frightening to the observer, characterized by some combination of apnea, central or occasionally obstructive, color change, usually cyanotic with pallor, or occasionally erythematous and plethoric, marked change in muscle tone, so these kids go limp, they choke, they gag, and in some cases the observer feels that the infant has died, right? So I think the danger for you guys is to not appreciate that, because you show up and the kid looks well, right? So you look at this well-looking kid, or a kid that's, doesn't look too, and you kind of dismiss the story as anxious parents or whatever, right? And I think that was the danger that happened in the pre-hospital world, was that these events were basically poo-pooed by EMS and dismissed, and a lot of reassurance, like false reassurance given, where it probably wasn't, the kid should have just been transported, right? So it's not a diagnosis, but it's a description of what's happened, and a broad range of presentations described in the definition above. So it's a useful term that we talk about to kind of a grab bag to say, okay, this was an ALTI, but it's not truly a diagnosis, right? It's a description of what happened. So it's a term that can provoke unnecessary anxiety and alarm. In 95% of the patients with these presentations, the cause is physiological or a relatively benign pathological condition, but that's not your guys' arena to make that decision, right? Like, my honest advice to you guys is, and having just reviewed more cancellations from Strathcona and St. Albert, I can tell you that your college is very, very, they're very much monitoring cancellations, right? I mean, that's their biggest thing that they are. So if you want to be having an appearance before your college, it's a good way to do it, right? Is be canceling on calls, because it'll come back to bite you. And that's not coming from the medical director community, that's coming from your college. I can just tell you that I've been involved in several of them, and that's where from my point of view, the majority of the things that I get involved with at this stage, it's very rarely that I'm involved in something other than, punitive stuff for cancellations, right? Because it's become problematic. And I don't know, I had this discussion in Strathcona because I just recently reviewed another event there, and I don't know where the mentality has come, or where it's been, where that transition has occurred in paramedicine. But I mean, I can tell you, in my career as a medical director, the number of cancellations has exponentially increased. The number of bad outcomes has increased comparatively to where we were at 10 years ago, right? So what does that tell you? Does that tell you that, to me, what does it tell me? It tells me that, okay, there's been a culture shift in EMS somewhere along the line that, we cancel on these calls. I'm not talking about alties in general. I'm talking in general about cancellations. And it's like, that's a dangerous game for you guys to get into. I'll full stop. That's all I'll say, right? I mean, for you guys to make decisions with limited information on a lot of these people, and make decisions like, with kind of half information, and particularly a lot of these decisions are being, all of the decisions that make my desk are decisions that are made in isolation, right? They haven't contacted online medical control. They haven't activated any of those kind of fail-safe things to say, give the sober second thought and say, hey, listen, you know what? Let me talk to the patient. I'll talk to the patient and we'll convince them, right? Or if they don't, at least you guys have done your due diligence. But any of the ones that I'm involved with at this point are, these decisions are being made in concert, and a lot of them have the, on your cancellation sheet or whatever that you guys use, will have clear indications that they should have contacted online medical control. And you can't cure stupid, I'm sorry, but I mean, if you're not going to make that call and you're going to look at that and ignore it or not, not even have that register, it's on you, right? I can't help you at that point, right? So, I mean, things go bad, I get that, but you know what? If you guys are making those decisions in isolation, it's on you, and your college will come after you. So, that's all I'll say. So that was my rant for the night, by the way. So, anyways. So incidence-wise, up to 6% in a variety of studies. Lower incidence in approaching 1% in larger studies. But typically, we're talking about young infants. Okay, we're talking kids in that 10 to 12 weeks of age life, right? So certainly, we consider it in kids less than a year, but the peak time of the event is in that 10 to 12 weeks of age range, right? So, I mean, I don't know how many of you have kids, but I mean, even as a physician, I knew that when my kid was really young, I was nervous, right? Like, I mean, I'm not a nervous guy, but I still remember when we brought our kid home from the hospital, I remember going into the room and I was like, is that kid even breathing? Like, I mean, even as a person that had been, seen, pediatrics and kids throughout my training, it's a nervous time, right? So certainly, in that age range, it's very difficult to actually, number one, do a good physical exam, right? And even do, have reliable, particularly physical exam isn't terribly reliable in kids that age, right? So for decisions to be made on kids like that just by eyeballing them is a pretty dangerous thing to do, I guess, is the bottom line. And I mean, we all know that, kids who have fevers less than, 2 months of age, those kids get a full septic workup, full stop. We don't even think, right? Like, it's a no-brainer for us in hospital. Kid comes in with a fever at that age, like, less than 8 weeks, they get a full septic workup. There's no debate about it. It's just standard of care, right? So, certainly, that time, that age range, like less than 3 months, is certainly a precarious time because things present that's when a lot of cardiac stuff presents, like more so at 6 weeks when the ductus closes and those kinds of things. But certainly at that age range is when we pick up on some of those things. But having said that, 50% of ALT-E events will be idiopathic. We won't ever find a cause, right? So, but again, that still doesn't preclude you from, doing what's right. And a lot of these kids, I mean, even if they present in hospital, I don't have an explanation as to what happened, I pick up the phone and call the stollery and say, this kid had an ALT-E. I don't know what's going on. I mean, we certainly do a workup, but they'll admit those kids and bring them in and observe them, right? So sudden infant death is a different phenomenon, right? So it's sudden death in a child without historical physical laboratory or thorough postmortem findings that explain the cause. SIDS peaks at 3 to 5 months of age, postnatal, 90% occur in less than 6 months. 7% of all kids who die from SIDS have a history of ALT-E, but the risk of SIDS increases with history of ALTI linked to central hypoventilation syndrome, seizures, or arrhythmias, right? So having said that, I mean, there's no correlation between ALTI presentations, sudden infant death. It's not, they're not the same thing, I guess, is the answer, right? So epidemiology, like the age range is different. There's no documented increased risk of subsequent SIDS and otherwise well-term infant who present with an ALTI, right? So there used to be a term that they'd say near miss SIDS. It's not really it's a misnomer. It's not the way you should look at it. So again, 50% is idiopathic. So in 50% of people or kids, you will find a cause for it, right? So there may be coexistence of pathology. Positive workup doesn't necessarily determine the cause of the ALTI, like GERD or whatever, if the kid's got reflux or something like that. But I'll just give you a list of the common etiologies of ALTI with the percentage of all explainable causes of ALTI that it represents. So GI symptoms, or GI, like GERD, reflux, those kind of things, 50% of the etiology of an ALTI. Neurologic, 30%, respiratory, 20%, cardiovascular, 5%, metabolic, 5%, infectious. I mean, child abuse always makes the radar, right? Something that's always hits the differential for us. And then other causes, right? So, just looking at GI, neuro, respiratory, good chunk of those kids will have that, right? So most common thinking is that these kids have these events because they have exaggerated airway protection reflexes. So the cough reflex isn't well matured, so they get contents into the laryngeal outlet. Instead of just stimulating cough, they'll get apneic, right? So it's not a stretch to figure out why that happens. So then kid goes apneic, of course they're going to get flaccid and their cardiac will change. And then, during upper respiratory tract infections like RSV, but other viruses, the laryngeal chemoreceptors become more sensitive, and then they get these episodes, right? So a lot of these kids will have infectious type things like RSV, bronchiolitis, right? Those kinds of things, and they'll have these episodes, right? So often, or occasionally, the ALTI is the first sign of a viral respiratory illness. And then more typically, they'll get a coryzal illness, bronchiolitis, appearing in the subsequent days. And this explains why you'll often see it during feeding or in the first hour or two after feeds, when the physiologic episodes of reflux are more common, and the common history of concurrent mild viral upper respiratory tract infection, right? So, I remember the one in Strathcona that that triggered a lot of this initially, and the one in St. Albert was, kid was feeding and kid choked, kid went apneic, flaccid, right? And EMS shows up, kid looks fine, and they basically, false reassurance or reassurance to the mom, say kid's fine, I'm sure it was like a bit of a new mom, whatever, right? And, overreaction kind of thing, right? And you can see how that pattern of behavior happens, right? But anytime that anytime I see a kid less than that, 2-month age range, or particularly 3 months and less, I see that come up on the triage board or on on our board to see, and already I'm thinking differentials and my index, the kid has to prove me wrong that they're unwell, right? Or that they're well, I should say. They have to prove me wrong that they're well, right? Because I'm thinking that kid, if the kid presents like that, I'm certainly thinking, and it doesn't always mean we're aggressively doing things, but we're certainly, disposition-wise, those aren't the kids that I'm eyeballing and, let my resident eyeball and then, I'll see you later, mom, kind of thing, right? I certainly go through the history with a fine-tooth comb, and, certainly these kids warrant observation, right? So almost all these ALTI kids require hospitalization for observation for the workup. I guess that's the take-home message, right? So for you guys to arrive on a scene with a 2-month-old and, attribute it to, overreactive mom or whatever, that's probably a mistake on your part, right? So some studies have indicated that patients can be discharged home if they have a history that's consistent with a benign episode, have a normal physical exam, and good follow-up. But any patient with an abnormal physical exam requires resuscitation should definitely be admitted. I think that's kind of a no-brainer. But so, and in published case series, if further events are going to occur, it'll happen within the first 24 hours after ED presentation in 98% of cases. So that's why it's a pretty easy sell for the Stollery to bring these kids in. I mean, you know, we're not talking about a ton of people that have these presentations or kids, right? Like, but certainly, you know, if we have that story, then they'll watch those kids on a monitor, you know, not a cardiac monitor necessarily, but a pulse oximetry for at least 24 hours. And then they'll go from there. So, extensive history, investigates all aspects of the episode. And I guess, you know, I always say, like, how extensive a history can you take, right, in an interaction like that, or pay the kind of attention, or even know sometimes the subtle questions that should be asked, right? So I guess, you know, as a protective person on your part, I would say I would default on the side of caution, I guess, is the answer, right? I mean, worst case scenario, you transport that kid, you know, kid gets discharged from hospital, at least the parents are happy, right? Like that, you know, the kid's been looked at and examined and everything else, right? So again, I don't know why, you know, in the past scenarios where these have been canceled, I don't know why people would take that risk on themselves, and I think a lot of it was due to a lack of awareness of this phenomena, right? So
A lot of times, though, it's the parents, even while you're going there, they'll come back over saying, like, well, they don't really want you anymore, they think the kid's fine. So it's the parents that are actually already have that in their head even by the time you get there.
Yeah, and that's fine, but I mean, I would, at that point, then I would at least put the bug in the ear that this is a phenomena, and I would get online medical control involved, right?
Yeah.
Because you're not going to stand down on the call, right? Like, you're still going to that event, right? So at that point, that's a good again, you know, use that resource, right? It's a good resource for you guys to use. And I mean, a lot of us, especially in this scenario, will get on the phone with the patient, right? And say, hey, or the patient's parents or whatever, and say, hey, listen, you know what? You know, I know the kid looks fine, but this event sounds concerning from what you described. You know, we'd like you to be assessed. And whether or not they go by ambulance or whatever, that's fine. I mean, if they cancel and say, yeah, we're going to take them to see, you know, we're going to go to the Stollery ourselves, or whatever, that's on them then, right? But I certainly wouldn't want to see you guys incur that risk on your own, right? I guess is the take-home message, right? Like, I'd rather you guys use the resources and be protective of yourselves to a degree, right? And you know, give that kind of advice to the parents, like, yeah, you know, I agree with you, the kid looks pretty good, but this is, you know, our suspicion that, you know, sometimes these can be these events, and, you know, would you mind talking to our medical director if you're adamant that you don't want to go? But, you know, honestly, I think most of the time people respect you guys' opinion, right? Like, you guys, I don't think you guys realize how much you're viewed as a medical expert, right? I mean, you guys may not necessarily view yourselves in those kind of thoughts sometimes, right? And but to a lay person, a paramedic shows up, and, you know, you see it all the time, right? Like, you go and somebody calls with chest pain, their ECG is normal, and they go, I'm not having a heart attack, and they go, well, not, you know, you're not having an ST elevation MI, right? But so they hear that, but they don't hear that, okay, well, it could be other things. All they hear is, I'm not having a heart attack, right? So I'm good to go, right? So you guys are their medical expert, right? But you have to remember what people process and hear, and I always, you know, people aren't as sophisticated as you are, right, with your medical knowledge, right? So, you know, they definitely trust what you guys say. So if you say, you know, we strongly recommend that you go to hospital, most people will take that advice, right? So, so where are we at here? So again, you know, you're doing like things like when's the last time you guys put a kid on a growth chart and did that? 0, right? So, I mean, you know, certainly you don't go over these people with a fine-tooth comb, right, like they deserve, right? So again, you know, a lot of these kids, you can eyeball them and they have some funny morphology or something like that, and then they have diagnostic testing and it's borne out, right? So investigation wise, you know, a lot of these kids will have, you know, some invasive testing done, and then, you know, they'll get a urine RSVs test, get some GERD testing. So it's not like they are just observed and do nothing. A lot of these kids will certainly get some investigations to make sure that there's no significant metabolic abnormalities, right? So incidence wise, 1 in 400 infant occurs in infants under age, but typically under that 10-week age. So again, you know, high index of suspicion. If you got a kid with some kind of an event less than 10 weeks, you know, I would be certainly considering that's an ALT-I, right? So risk factor wise, male gender, feeding symptoms, feeds with a cough, age under 2 months, RSVs kicking around, they've already been under general anesthetic, event history, what are important things? So were they awake or asleep? Were they prone or supine? When did it happen? How did it happen? Were they feeding? Were they coughing, choking, vomiting? Was there skin tone, muscle tone, event duration? You know, did you have to do CPR, right? If you get the story that the parents thought the kid were dead and they were doing CPR, probably pay attention to that, right? So fever, rash, poor feeding, irritable, decreased level of consciousness, contagious contacts. If they're premature, developmental milestones met, history of trauma, or, you know, obviously if you saw a kid with visible trauma at that age, you'd be certainly thinking non-accidental trauma, right? Previous similar episode, family history of SIDS, neurologic cardiac disorder. And then, like I said, you know, most of these kids, they'll get observed and monitored in most cases, right? So, I mean, I don't even think about this too hard, right? If I get a story like this, and they show up at the ALEC, I call the stollery and say, hey, listen, you know what, I'm concerned about this kid. Would you bring him over and admit him and observe him for a couple hours? And we don't get any pushback from that, right? So age under 2 months, you know, sometimes they'll get discharged with a home apnea monitor. If they find a specific cause, they'll treat it, but remember 50% are idiopathic, and then sometimes they'll get the GERD management. So obviously, mortality increases if they've got a serious cause to what happened, or if they have central hypoventilation syndrome, or if they have seizure disorder or cardiac arrhythmia that caused these events, right? So if they got something significant that caused it, obviously the mortality goes up. So again, higher risk if they're aged less than 28, significantly premature, prior medical illness, kid looks unwell, and then you know, obviously if they have more severe, prolonged, more, you know, several events, then obviously it's certainly more concerned that something problematic is going on. So that's it. Any questions about ALT-Is or something? Have I ever reviewed that with you guys before out here? Or? Okay. So, I mean, is that something that is still kind of a knowledge gap in the paramedicine world, or something you guys know about or had heard about, or because certainly it's been, you know, in the medical community, it's a known phenomenon, but certainly when I presented this several years ago, when these events were, you know, hitting the radar, it was certainly identified, you know, from my point of view as a knowledge gap, and something that, you know, people didn't even know what we were talking about when we initially presented it, right? So certainly it was, you know, no fault of your own that you guys didn't know about it, right? But, you know, I think there's been enough talk about. Probably not, no, because neonatal NRP would strictly be like, you know, immediate birth type stuff, right? So, yeah, yeah,
Like every newer employee or student I've had in the last 4 years, I've had to explain it to them.
yeah, yeah.
It's not something they're getting readily talked about or anything like that.
Yeah. No, and that's fair. I mean, that's why, you know, I think, and again, how many guys were at the symposium out in Edmonton? Because there was Bill Sevcik. I have his presentation as well, but he did a little blurb on one of his cases was an ALT-I event or whatever, right? So I can pull that up too, because I think it's here, but printed that one off as well, but that's a kid with RSV, I think. Here, I'll just roll through this quick, and then we can see what. So this is the EMS one that was done here. So this is a kid with bronchiolitis, or sorry, with croup, which we talked about already. This is a kid with, no, okay, this is Alti. So we can go through this case, 'cause that's a good one. There's a good tie up to it. So EMS called to a 7-month-old female. Family's concern is Emily had awoken from a nap, startled awake, cried out loud, and then went apneic. Mum blew into the child's mouth, and infant started to take child's shallow breaths. So these are based on, these are put together, these cases were put together by the educators, like for AHS, EMS, and they're real cases, right? So this is the story. So the mum blew into the child's mouth, and infant started to take shallow breaths, right? So you hear that story, and you're like, okay, well, that sounds pretty significant, right? So Emily had a bit of a cold with an intermittent fever, controlled with Tylenol, runny nose, full-term birth, no complications, immunizations are up to date. On EMS assessment, Emily presents with cyanosis around lips, lethargic, not crying, grunting is present. So I don't think any of you guys are going to leave a kid like that at home, right? So anyways, SATs of 90%, respiratory rate of 50 to 60, heart rate of 100, 35.2, BP of 74 and 59. So given some O2, 4-lead ECG, 2 more apneic spells en route, which required physical stimulation. So then again, that goes through the what I talked about with an Alti. So again, apnea, color change in muscle tone, choking, gagging, and parents concerned that the kid died. So again, going through what the causes are, GI symptoms, respiratory stuff hits the highlights, right? If you think of those 2 things, and CNS stuff like seizures, right? So their numbers are a bit lower. The 25% remain unexplained. But again, those are the common diagnoses that we went through. So much the same as stuff that we talked about, right? So this kid gets a workup in the emerge and is discharged with Alti secondary to a viral upper respiratory tract infection, right? So that's basically it. But I don't think I have much more that we'll go through with you guys tonight. I think we'll stop there. So any questions about any of that stuff, or useful, hit the mark? Okay.
Thank you.
Yeah. Yeah, again, just always just let Mindy know if there's a particular topic that you guys want covered or whatever. I'm happy to, put something together. A lot of them I have, like, I would have a presentation already prepared, so if not, I can put something together. But we have a lot of the other services, like Strathcona and Leduc, have the FR, the residents come out to do presentations, right? So I may talk to Shane about that, and because they come out and do there's almost like a rota of topics that they cover, which I kind of base a lot of my talks on that rota with you guys. But they have basically, they come out and do like 6 or 8 talks in a season with those guys. So, but Strathcona and St. Albert pay the residency for them to come out and do that. And I usually attend as well, but I do a lot of the same topics that they would do, so it doesn't matter. I don't mind coming out. I like the FaceTime with you guys and seeing you. And yeah, and honestly, if you guys ever have questions when you're in hospital bringing patients in, don't see a lot of you guys at the ALEC, but if you ever have questions or even just say hi to me when you're in the department, I'm always happy to see you guys and chat if there's questions or if you want feedback on stuff. I think one of the residents is actually trying to get, because I think we've realized that there's a lack of like real-time feedback, like for you guys, like you want to know, like, particularly not so much outcomes all the time, because outcomes are, sometimes it's interesting. I don't like to get Shane will occasionally forward outcome, the outcome. A lot of times I don't get it. Like, a lot of stuff doesn't appear on Netcare for a while, so I can't always give like real-time feedback, but generally I try and get him that feedback back if there's a case that you guys are really interested in the outcome or what the diagnosis was, if it wasn't clear by the time you guys finished up or whatever, if it was just a bizarre case that you want to know. I mean, that's the other thing too. Like, if there's particular calls that you guys want to flag for us to review at one of these meetings, that's a good thing to do too. Like, if there's a good call that you guys had where things went well, or you have questions about, it's often a good forum to have your peers hear the story, and then make some decisions collectively as to, okay, what would you guys have done in this scenario presented with this case, right? Or how would you have proceeded here? So certainly if there's particular calls that you want reviewed at one of these meetings, we can make that happen too, right? So it's a good forum. I find primarily, like, in the fire services, those are far more well received. You guys seem like the fire services seem to come from a culture of quality QI, right? Like, you guys are definitely interested in, how can we do something better, right? If you see a fall down and it's not that threat isn't there, like sometimes you see in other departments, right? Like, you guys are far more, I think probably just from the collegiality that you guys work with on a regular basis, you guys are far more open to, having your dirty laundry aired, or not even dirty laundry, but just you're far more open culture, right? As far as how you think about things, and just want to do a better job. So it's all good. So yeah, hopefully, just be cautious of your cancellations. I'll say that. It's
Guess after that little rap, we shouldn't be seeing any.
yeah. No, I just think from, like, I actually came down pretty hard on the guys in Strathcona the last meeting I had with them, because I'm like, that's where I came from, right? And to see the change in behavior is disturbing to me, right? Like, and it's just like I'm trying to think, well, where does that come from? Like, where has that shift happened? That, it used to be, one of the older guys said, it used to be you call, we haul, right? And there was not a lot of debate, and I think a lot of it has come, from hospital wait times and those kinds of things. You guys figure, well, we can, maybe save the system, but honestly, like, you guys are making decisions a lot of time on limited information. So if you're making some of those high stakes decisions, certainly involve OLMC. So at least you have some degree of protection and second thought on it anyways. Good. Thanks.
Thank you.